Hello, everyone, and welcome to our webinar on geriatric pelvic fractures, improving patient outcomes and care with a focus on healthcare economics as well. This webinar is sponsored by CurvaFix, and we appreciate their support in delivering this really important information. I'm joined today by Rob Westphal from Cleveland, Ohio, and Michael Tilley from Galena, Kansas. And we're going to talk a little bit about how we've implemented geriatric care, pelvic fracture care pathways at our institutions. And then we'll have some time for question and answer. For those of you who are interested in giving us or providing us some Q&A, please use the question and answer feature in the Zoom webinar box. That'll give us a chance to review those questions. We may answer them real time or elevate them to the discussion at the end. So feel free to really be aggressive with the use of those that Q&A session. There's also a chat function on Zoom that will not be as well visualized during the course of this webinar, so I'd really tell you to focus on the Q&A. My name is Samir Mehta. I'm Chief of Orthopedic Trauma at the University of Pennsylvania, and my focus in today's talk is really going to be about the use of the CurvaFix implant to provide value-based care in the care of these patients with fragility fractures of the pelvis. When we talk about pelvic fracture fixation, this is a complex arena, right? It's a combination of patient demographics, especially in the frail population, along with hospital factors. It requires a resource allocation because these patients are typically older, they're typically frail, and it requires a combination of PT, social work, case management, the orthopedic surgeon, the medical services in terms of clearance for these patients, the risk stratification. And so it can be harrowing to take care of this population and struggle with trying to get them better. At least in my practice, the CurvaFix implant has allowed me to really elevate the care of these patients in a way that I think meaningful, allowing them to have shorter lengths of stay, allowing them to be more active, at least in the hospital and then post recovery. When we talk about geriatric pelvic fractures, there's a tremendous growing body of literature around these injuries. Not dissimilar to what we saw with geriatric hip fractures a couple of decades ago, we're now starting to realize that pelvic ring injuries in the frail population has a tremendous clinical interest as well as a value-based interest as these patients are growing in size and volume at all of our institutions. And when you look at the geriatric pelvic literature, really what it comes down to, the crux of this conversation is looking at non-operative and operative treatment of geriatric pelvic fractures and trying to understand and develop a mindset around what patients would benefit from surgery and how would that impact healthcare and the health system. So as we think about this, where do we stand currently? It's a growing challenge in our patient population. We have a scenario now where we have more and more of these patients who are coming in with these geriatric fractures. There is good literature to support the idea that operative management does better than non-operative management. And as a result, we're seeing this transition to increased surgical treatment. Now, again, this is a frail population. So obviously the opportunity to do percutaneous or minimally invasive surgical stabilization likely is better for these patients as it can improve short-term outcomes. You're doing less soft tissue dissection, you're getting less blood loss. And it may actually impact survivorship because you're getting them up and getting them moving way faster, right? We tend to, and I think all of us would agree, we make these patients weight bearing as tolerated. The theme you're going to hear, the theme that's going to be emerging is that we look at these fractures a lot like we look at geriatric hip fractures. We would never not fix a geriatric hip fracture, or very rarely treat those non-operatively. Very rarely would we make those patients non-weight bearing or modified weight bearing. We do the same now, at least many of us, for geriatric pelvic fractures because it's the same type of patient with the same or the very similar kind of injury. So I think part of understanding or part of this is, can we think about what the economic impact of an implant like this is, because it is more expensive than traditional fixation, right? Or at least could be more expensive when you look at the overall cost around it. Or maybe it's not. And that was one of the questions that our value analysis committee and our new products committee had was like, okay, we implement this new technology, we implement this new technique, we have these new pathways. Does it really make a difference, right? Are we having an impact? And so as it is with many new products in our health system, we have a very structured governance process to get new products in. Now, this is not like it used to be, right? So we have a new product committee. We actually just renamed this to the New and Emerging Technologies Committee, NETC. And then after it passes through NETC, it has to go through the OR committee. And then from the OR committee, it goes to the value analysis committee. And then from the value analysis committee, it goes to the contracting committee. And about a decade later, I get the use of new technology. I'm somewhat teasing that the health system is actually relatively efficient with this, recognizing the importance of new technologies to help afford our patients treatments that they may not normally get. But it is a structure to really understand what new technology offers and is it the right decision in an environment where there's also fiscal responsibility. Many times when we come to our new technology committee, we often will go with the concept of getting pilot data or doing a pilot study saying, hey, we have this technology, we have this approach. Can we try it on a handful of patients and see what happens, right? Follow them acutely in the hospital, follow them downstream, look at how they do clinically, look at the cost of care, look at complications, and then let's put the whole picture together. It's not just the singular event of their injury or the singular event of their surgery, but rather the entire continuum of care. And then ultimately, the goal of, I think, healthcare in general now is value-based, having a value-based rationale for moving forward with employing technologies or techniques, right? And that is providing both high-level, cutting-edge care, but doing it in a fiscally responsible way. And so when we talk about fragility fractures of the pelvis, and we have these conversations across the country, across the globe, really, the patient and surgeon experiences are not that dissimilar across hospitals and health systems, right? And this is the classic story, right? Or this is one of a classic story. 90-year-old male, fell from standing, had right hip pain. I'm not going to go into the detail of sharing his CT, but he has a minimally displaced acetabular fracture. He cannot ambulate. He's two-person assist. He's not getting into a skilled facility. He's having trouble getting discharged. He's got a whole host of medical problems. And all he wants to do is walk and go home, right? He wants to get home to his family. He has a dog at home. He's worried about the mail that's in his mailbox. He just wants to get that heck out of the hospital, right? And so he's at an outside hospital. He's transferred to our hospital on day 4. So it's been 4 days of him sort of being there. And what do? We think, because we're a tier 1, level 1 academic institute, maybe if we treat him non-operatively, he'll get better on his own. But of course, 2 days go by and he's still no better. And so finally, we operate on him a couple days after he's been at our hospital. We put 2 percutaneous screws in, minimally invasive. We make him wayfarers tolerated. He goes home the next day, right? Think about that. We lost 6 or 7 days in the care of this patient. We kept him in the hospital on what was a relatively percutaneous, very minimally invasive procedure. This is his 4-month x-ray. He's full wayfaring, and his hip isn't what is bothering him. He's got an arthritic knee, right? That's what really is bothering him more than anything else, which is his baseline. He's a grumpy old guy, and he's very happy to be home with his dog and his mail, right? And this is the story that helps rationalize or deliver us to this idea of we should do a pilot, or we should start to think about what this patient journey looks like. And we're going to hear more about that from Rob and Mike in terms of patient journey and pathways. So for our pilot, this is our patient that helped fill our rationale. This patient presented to an outside hospital that's in network, so a sister hospital. They were there for 6 days attempting non-operative treatment of a pelvic ring injury. They were finally transferred to us at day 6. They had significant pain. They were unable to wayfare. They had an inability to ambulate, even with a 2-person assist, right? Prior to this fall, she was a community ambulator with a cane for longer distances. She had past medical history that's pretty typical for this patient population. Heart disease, heart failure, hypertension, diabetes, the roulette of acronyms. And then after she was transferred to us, after 6 days of attempted non-operative treatment, I don't want people to think every pelvic fracture that comes in the pen gets fixed, but we still attempted 2 more days. You could argue that there was probably little reason to do another 2 days of non-operative treatment after she had done 6 days of previous non-operative treatment, other than maybe a little bit of, well, maybe our therapy team is better than their therapy team, right? But that didn't work. And ultimately, we took her to the hospital. After 6 days of non-operative treatment and 2 additional days of non-operative treatment, we had a long conversation with her. We talked about her goals of care. We talked about the fact that we would allow her to be immediate weight bearing. We talked about disposition to home or with acute rehab, or we have something called 10 Care at Home. So they essentially have a skilled nursing at home program rather than sending her to the OR. And we did. We fixed her. She went home 1 day after surgery. This video is her walking in clinic at 2 weeks with a walker. That's her 6-week x-ray. And she was thrilled. And her biggest issue was, why didn't we do this day one? Now, again, I don't want you to sit here and think that we operate on every pelvic fracture that comes in, but that concept or that question was not I was listening to what she was saying. And so when we went to our new products committee and our value analysis committee, we really said, what's the rationale behind doing something like this, right? What's the rationale behind using this implant, this technique, this technology, when we have screws available? And I'll ask the panel later, why not just use regular screws and do the same thing? So the rationale was, we can decrease the rate or risk of doing open procedures, which then decreases OR time and decreases blood loss, right? Every unit of transfusion at our hospital is an additional $600 of cost, right? So if I can do something percutaneously and not have to do a big open procedure, I can save a unit of blood, maybe a couple of units of blood. I can also minimize my OR time, which might allow for additional procedures to be done that day, whether it's additional trauma procedures or other non-trauma procedures to help throughput in the hospital. It limits screw penetration into the joint, right? So because this is a flexible implant, I'll show you that in a second, I can then get into corridors that I may not normally be able to get into. I can avoid neurologic injury. And obviously, especially living in a city like Philadelphia and a state like Pennsylvania, there's medical legal implications and cost of medical legal issues. I think it also improves the potential for improvement of operational efficiency. Because they're doing a percutaneous procedure, there's decreased OR time, right? I'm not spending as much time doing a big exposure, closing a large wound, having to position and prep and drape in a certain way, setting up for lines because we're doing a percutaneous procedure, so there should be minimal blood loss. So anesthesia can spend less time sort of preparing the patient. There's decreased staff burden. I mean, when the staff hears we're doing a percutaneous procedure, there's generally, a little bit more enthusiasm around it because they know they're not going to be opening as many steps. They're not going to be running around as much. There's going to be less instruments and implants to turn over. And all of that is for a long day. This is really appreciated by your OR staff. And then obviously this concept of what we talked about earlier, this concept of increased throughput. By decreasing OR time, can we get increased volume through the operating room? One of the things that I really utilize this implant for is immediate weight bearing. Because it's a larger diameter, because it fills the canal and the corridors of the pelvis, I am very aggressive about allowing patients who have this kind of an implant to be immediate full weight bearing after surgery. With essentially wanton disregard. I say that in a good way, or benign neglect. I want them to walk on it. That's the whole point. Now, I recognize that, as you saw in that video, that woman was walking with a walker, but I'm happy to have them put as much weight as they want. And I think that's really important in terms of their disposition and their ability to be mobile after this case. And then obviously there's the opportunity from a business development perspective for your hospitals and institutions and your own practices, right? This is a new technology. It could be a differentiator. Referrals in from like our sister hospitals. The cases I showed you were from all either a sister hospital or a regional hospital where they don't have surgeons who do this kind of technique or use this kind of technology, and allows them to improve their access and decrease their length of stay. It allows us to have increased surgical volume as well. So we do have the ability to differentiate in our region. So what our new Emerging Technologies Committee, our NECC, agreed to with us was a 5-patient pilot. We wanted this trial, and I'll use the word trial somewhat subjectively. It wasn't a multi-center trial, but a trial for our institution. We wanted to be really thoughtful about the types of patients that we enrolled, right? This is, as you can see in this diagram, a flexible implant. You're able to sort of guide this implant down a canal, almost like if you were threading a snake down a sink. You can get it down, and then it has the ability to become rigid, right? There are cables in this that, by turning a set screw, you can then take a flexible implant and make it a rigid implant, providing stability, which is tremendous. So we said, let's think about, let's be thoughtful about the kind of patients we're going to include so that we can really try and show value in the use of this implant. So we thoughtfully included the patient who had originally been treated non-operatively, maybe like the patients I showed you who would have just done PT endlessly until we could get them out of the hospital. We included 2 patients who would have been done with procedures with open reduction internal fixation, so either using 2 implants or a single pre-contoured implant. And then we included 2 patients who have a sacral dysmorphic pelvis, which requires multiple screws put in bilaterally, so there's increased OR time. You're using multiple implants as opposed to a single implant with the CurvaFix. And so we were trying to be very thoughtful about who we included to see if we could compare those patients, have patients that we had historical controls of, but also then would show the benefit of a product like this. And so what we looked at was, what was the price per case? The cost of this device and supplies is roughly $4,000 per screw. We talked about the potential anticipated use of 9 per year, which turns out that we're doing a lot more than that when we start to really look at this population. We thought there would be about 5 new cases, patients that we would historically never have done surgery on. So they are surgical patients now because we have this implant, but historically we would not have operated on them. And 4 patients that we would have done historically open that we're now doing minimally invasive because we have the opportunity to use this implant. And we looked at comparable devices or comparable systems that are out there that we could use in lieu of this or would have used in lieu of these screws. And there's a lot of numbers on this slide. Fortunately, I'm not a numbers guy. The VAC and the new product committee put these numbers together. I just sort of borrowed their slide. So they dumped in the numbers. They looked at insurance payers. They looked at the NPR, the net patient revenue. They looked at margin. They looked at cost per procedure, what we used to do, historical controls, all of that stuff, right? That goes into some of the fiscal modeling of all this. And ultimately what they found was by utilizing these implants, by looking at the 5 cases that we did our trial on, and by comparing it to the historical data that we had, we actually had a margin per procedure, increased margin per procedure of $20,000. So from a financial perspective, the hospital actually, which is not common, said, we would like you to take care of more of these patients. We see a fiscal opportunity in helping these patients aside from the clinical benefit that you're providing. And so they've been amazingly great partners in helping us facilitate the care of these patients, having them come in, and you're going to hear a little bit later about care pathways, similar to what we did with geriatric hip fractures, we're now doing with fragility fractures. It's not quite as streamlined as the geriatric hip. We still, I would say, are very conservative in our approach, but we definitely have trended more towards surgery over the last couple of years since we've had access to instrumentation and implants like this. And so the second part of the pilot, and you're going to hear more about quality improvement projects later, was to look at, just to do a very high level overview of, are we seeing an improvement in our sort of the quality improvement metrics that that the health system might care about. And so prior to implementing this pathway and this care tool, CurvaFix Crew, what we found was that the average length of stay for geriatric pelvic fractures in our system was 9.2 days, with the majority of patients going to skilled nursing facilities, which that in and of itself adds on time to get a patient to a skilled nursing facility. By utilizing our protocol, which looked at 8 patients that we operated on by hospital day 3, so if they failed conservative treatment, we said, listen, we're going to talk to you about surgery. If you want to proceed, we'll do surgery. The patients who were in our Fixation group had a length of stay of 4.8 days, so almost half of what it was in our non-operative group, with the majority of patients actually going home. So the overall cost of care goes down for this patient population. And when you look at the financials, when you just looked at this globally, we were saving enough on the length of stay that it was paying for the implants themselves. This doesn't even include the margin contribution of the patients overall. It just talks about the length of stay alone justified the use of the cost of the implant. And so as we start to piece this together, for us, it became a very straightforward solution, if you will, because the value data, the cost data, and the clinical data really came together very nicely. And anecdotally, and not even anecdotally, we've done some work on this and have some research coming out. we do believe, and we do have data that shows that patients do well with early fixation and early mobilization, right? So you couple all that together, and when we talk about value-based care, it is clear that by utilizing the CurvaFix implant, by allowing for immediate early weight bearing, by mobilizing these patients early, by taking good care of them, by giving them stability, we are improving their overall care and overall value to the health system. So with that, I'm going to turn the program over to Rob Wetzel. Rob, the floor is yours.
Well, I was just about to type an answer to the first Q&A, so
I'll jump in there.
I'll have to wait. Yeah, and it's actually a good question for you because it has to do with value. So, and that's a good segue. I just want to remind everyone to please use the Q&A and use the chat. We'll be monitoring it while each other is talking. So Mike and Samir will monitor while I'm talking and vice versa, and try to get all of your questions answered. And stay tuned if you can to the very end. There's a nice little CME QR code for you guys to tune into and claim some CME for tuning in. So thanks, Samir. I really appreciate the first portion of this webinar, and thanks again to the CurvaFix folks for putting this on. I'm going to shift gears a little bit and talk about specifically more the pathology and the problem with elderly pelvic fractures and the care pathway protocol that exists that a few of us sort of early adopters within CurvaFix have taken under our wing, and one of the quality projects we're working on at my hospital at UH. And we're also going to, I'll show you some cases as well. I'm going to need to take control. Okay, sorry, let me just back up, bit of a delay. So I just wanted to call attention, to the folks in the audience that the elderly patient with any injury, and obviously we're focusing on pelvis fractures here, but pelvis fracture specifically can cause a condition that usually when I teach this to my residents or fellows, I'll call this the immobile elderly or the elderly immobile person. That is the specific pathology without any major details that we're trying to isolate in this particular discussion, this particular academic exercise, where we're trying to isolate what happens to someone who's elderly and has an injury that causes them prolonged immobility. Obviously, we're all aware of osteoporosis and the increasing rise of age in the baby boomer population. And with that increasing rise of age in our population comes an increasing rate and incidence of osteoporosis. With that, very low energy injuries are going to cause pelvic fractures. Just as Samir said time and time again, the corollary between this sort of injury and hip fracture is really at the forefront of what the leaders in orthopedics are trying to draw that connection between and get the thought leaders on the same page and try to really get the treatment plans aligned and not just the understanding of the pathology, so that we can be more diligent, more aware, and more aggressive when appropriate for certain elderly immobile patients, okay? There is definitely evidence that a conservatively managed patient that cannot get up and get out of bed demonstrates poor outcomes. In addition to that, there's also a significant financial burden, not only to the patient, but to the patient's family. Are they going to be a prolonged state of nursing care that really drains their bank account and puts them in a position where they cannot get up and move, such that they are requiring 24-hour round-the-clock care and other issues that the family may have to deal with, losing activities, daily living, and independence, and so on and so forth. So that's the problem we're trying to prevent with this particular movement. Now, there is a large body of evidence that exists. Now Samir was talking about some evidence that we have to support the use of certain implants and certain movements toward treating a little more aggressively these problems. But there is a quite larger body of evidence that exists that an immobile patient that cannot return to their previous state of mobility and independence, who are managed without surgery, experience one of several, and they're listed on the slide, one of several complications, whether that be mortality, increased length of stay, increased risk of 30-day readmission, loss of independence and mobility, etc. And really what we're boiling down to is that bad things happen to older folks that can't move, that can't get out of bed. And this is an argument or a debate or an academic exercise that honestly, if you boil it down to that, doesn't need to be discussed so much, because this has been done with hip fractures. This has been done with patients who can't move. Now, this population is a little bit different than a hip fracture population. In that, I think if you were to look at someone's x-ray as a treating physician, or even someone who has any sort of part in the care of this patient, we're talking about someone with an intertrochanteric femur fracture or a femoral neck fracture that no matter what happens, that patient is not standing and not moving. They have an immediate loss of structural support to their appendicular skeleton. It's not going to allow them to move. In a pelvic fracture, particularly a lateral compression type injury that you look at and you're like, oh man, I mean, it can't be that unstable. However you define that, is really isn't going to maybe keep someone down. They should be able to stand and move. The radiographs can really be bad actors, and I'll get to that in a slide or two, but the pathology sometimes doesn't always correlate with the radiographic injury. So we have to start thinking of these patients in a bit of a different light. Fortunately, and the purpose of this webinar is to express to everyone here in attendance that the treatment for this pathology is in evolution. We don't have to stay within historic and possibly antiquated treatment patterns where no matter what the patient's doing, we're basing the treatment on the radiographic injury. If someone has a quote LC1 pelvis fracture or a stable based on appearance lateral compression type injury, which I would argue and most would agree is the most common type of injury that this population is going to sustain. If someone has that particular fracture, they're going to look at that x-ray and say the historic treatment is conservative management. Why would this patient need surgery? This x-ray is barely displaced. This injury can't be unstable. How can this patient still be in bed? We're trying to change that and really just evolutionize the thinking pattern to try to put it more into a functional category where if this patient can't get out of bed, we are going to avoid a number of problems that exist in this elderly and mobile patient, all of which are listed here, whether that be dermal with skin breakdown, pulmonary, respiratory atelectasis, pulmonary embolus, venous thrombotic events, cardiac deconditioning, respiratory infections. I mean, all the things that are listed, whether it's GI, GU, a general amount of dehydration. I think we can all relate to a patient that has undergone a very rapid and very severe deconditioning from an injury that keeps them in bed just for a couple of days. I mean, Samir's case example was a perfect example of what's going on. Someone that sits for 4 to 6 days. I mean, as a 40-year-old guy, I mean, I couldn't imagine laying in bed still for 4 to 6 days and getting out on that seventh day and feeling pretty spry. And imagine being in your 80s or 90s with a pelvis fracture, trying to do that with really what's translating to very minimal mechanical stability if this person fails these particular physical therapy trials. So I want to segue into a little bit of our pathway. I'm going to let Mike take a little more of the details of it, but I want to sort of intro into that, and then we'll get into some cases to demonstrate some examples of how we can use this CurvaFix implant and other implants to help stabilize some of these injuries that are keeping people in bed. So where are we going? What direction do we have? What are our tools? What are our resources? So we are orthopedic surgeons, yes, but maybe we need to better engage the emergency department. Into play? Do primary care physicians come into play? Where does a geriatric fracture clinic come into play? Are we going to treat the root cause disease, which is osteoporosis? How are we going to structure these protocols? These are all the questions that are going through my mind when I start to think about how we're going to treat these things. How many different facets of this particular disease are we going to tackle all at once? Well, I think a good way to start is number one, involve the emergency department, the physical therapy department, and the orthopedic department. And then you'd loop in primary care, rheumatology, maybe endocrinology, maybe geriatricians, gerontology, things like that. But when this person comes to the hospital and they come to the emergency room, that's their point of first contact. And what I see so often in my own health system, and this is probably occurs more commonly outside of the level 1 trauma center. So there's 19 other hospitals, my health system, someone will come in, they'll have a superior and inferior pubic ramus fracture on x-ray. You can see that. There's not a CT scan done. They're not sure if they need to do that. They can see the injury. They know exactly what's going on. They consult the orthopedic surgeon to no fault of his or her own, who's doing primary total knees and total joints, scoping ACLs and things like that. It's a ramus fracture. It's not that displaced. Why would I do surgery on that? I've never seen in all my years of training that would need surgery. That's the mentality we're trying to erase. We're trying to buck that mentality a little bit such that we can evaluate that patient not in a moment in time, but as an ongoing process. And that's where the collaboration between these services is most important. Physical therapy needs to be involved. And no, these patients don't need to be admitted to the orthopedic service, but they need to be followed, not momentarily decided upon. It's not a moment in time, it's an evolutionary process. Physical therapy needs to be involved, and they need to relay those things back to the orthopedic surgery service, or the primary service needs to relay those things back to the orthopedic service and try to tell us what's going on. We need to know what the patient's doing after that particular moment. In the emergency room, we really need to get advanced imaging on these patients to ensure there's no posterior ring, or rather to identify a posterior ring injury, which may incur even additional stability than an isolated anterior ring. And the vast, vast majority of patients have that posterior ring injury. It should cross that hospital's mind, that provider's mind. How can I get in touch with an orthopedic trauma specialist? Sure, percutaneous pelvic ring surgery is fairly easy for a trauma surgeon, but not every surgeon does that. Not every trauma surgeon does that, and definitely not every general orthopedic surgeon does that as well. So let me just put this on their radar so that when it happens, I want to make sure I can accept this patient and transfer. I want to be aware of this patient, fast track them to the OR, or fast track them to an evaluation by a physical therapist at your hospital, and lay your own hands and eyes on the patient. So letting someone know, getting that to be more at the forefront of it. And then as the physical therapist goes, this is a protocol that was developed at a University of Missouri. We do this in Cleveland. We are part of a larger study that CurvaFix is sponsoring, where you can do a bed mobility test followed by a standing at the bedside, followed to at least getting 25 feet of walking, or to the patient's desired baseline function. If they fail those things within 28 to 48 hours, the trauma surgeons are notified, and we're considering at that point surgical discussion with the patient. And we talk to the family, talk to the patient, let them know what the benefits are, and we can intervene at that point if we so choose, if they so agree. And we have experienced at least a fairly significant anecdotal and early data collection, at least very good results with mobility, early mobility in particular, and very good results with decrease in pain. Those coupled things help keep people off medications. They reduce delirium. They get them out of the hospital. They get them back to their lives, their ADLs, their independence. Okay, so this is what we're trying to do with this movement when discussing geriatric fragility fractures. And looking into the future, I think spreading this fragility fracture of the pelvis movement to the emergency department, to primary care, to geriatricians, like I mentioned before, and particularly physical therapists, who are really the first hands-on provider to really get them out of bed and see what they can do, teaching them this information, teaching them this protocol, and then having them relay back sooner rather than later to the surgical service. They're not doing well. We potentially may need to intervene in this particular case. And then what we're doing at our place is tracking these lives that are impacted. This is a very new quality initiative that we've begun, looking to see how many more patients can be reached, the potential improvement in all the outcomes in a prospective manner, and looking for future partnerships with bone health clinics and people that manage osteoporosis medically. And there is a concept that was started here by CurvaFix of a fragility fracture liaison. Well, they will hire a particular individual to work with your health system to educate and identify these first contact providers and really preach this gospel that we're trying to spread, to try to get this message out to the people that are seeing it even before the orthopedic trauma surgeons, so that they can bridge those gaps and make connections. And it's been a great partnership so far. So quickly, I don't want to belabor the case part of it. I want to give Mike ample time and then also for Q&A, but I'm going to go through a couple cases just to demonstrate how this can be missed. So this is a 92-year-old woman, proud Eastern European woman who is just independently ambulatory, cooks for herself every day. Her son lives down the street and kind of keeps a secret eye on her, but she's very independent, and that's her thing. Very low energy fall. And she presents us with the x-ray you see on the left. Initially, a CT scan wasn't done. And it's a pretty benign looking x-ray. But if you look at her CT scan, you can see she has a pretty significant posterior ring injury through her posterior ilium. And that's a pretty unstable fracture pattern, okay, radiographically. And I was air quoting on instability earlier when I was referring to the LC1 type pattern, because we haven't really defined as a community whether or not that's going to be mechanical, radiographic, or functional. I would tend to lean toward the functional category when we're talking about fragility fractures. And this person did not have good function. She was not able to stand. She was very frustrated by that. Her pain was too severe. They went through 1 day of more significant narcotic administration, completely went delirious, sundowned. Her son was very upset. And then we had this discussion about how can we intervene surgically. So what was decided was that we would take a mostly percutaneous approach for this particular individual. She was profoundly osteoporotic. She had this would be described as an LC2 type injury or posterior ilium injury that exited through the posterior iliac crest into the sciatic notch. This was initially stabilized with a CurvaFix implant in that corridor, and then treated on the superior more aspect of the ilium just to augment fixation given her osteoporosis along the posterior iliac crest. She went on post-op day 2 to a skilled nursing facility, and anyone who's taken care of an intertroch, which is a lot of people who has been involved in that, to leave before post-op day 3 even is a small miracle. I mean, even just to get Medicare approval. I mean, she had her 3 nights minimum. She was in the hospital. She had surgery the next day. She failed her first test. 2 nights, she's into a skilled nursing facility. That's a testament. Sometimes this takes 3 and 4 and 5 days at our place, to be honest. And just to give you some more long-term follow-up or midterm follow-up, she had her immediate hospital x-rays on the left, her first post-op visit in the center, and this was a 3-month visit. Now, this particular patient, I really need to update this. She's way more than a year out, and she was, by 3 months, extraordinarily happy with her outcome. She was home after just 4 weeks, which I think is, for a 92-year-old, pretty remarkable. And she wasn't just home. She was home and getting back to those previous activities, daily living. I mean, and I say this as a joke, but I mean, she would bring cookies to the hospital. She was super happy, or to the office rather, very happy with her outcomes, very happy with how fast she got back. She thought, man, I'm 92. I'm never going to get back to what my daily living would be. And she did, and she was quite happy. Another case of someone, this is a pelvis fracture that looks more like a high energy injury. And I put this in particular because there's a little bit of crossover there. This person was essentially in a nearly no speed fender bender, like hit the person in front of him barely moving. And he had a history of prostate cancer, which in this case, it's not osteoporosis, but he had a mixed lytic blastic type appearance to his pelvis on x-ray. And you'll see on the CT scan in the next slide I'll show. But he had a very low energy injury and had a multitude of injuries in his pelvis. And you start to think about, how can you manage all these different parts of the pelvis? And he had a very typical kind of sharp male angle to his symphysis. He had bilateral pubic roots. He had a posterior LC2 injury on the right. And on his CT scan, as here I outlined the x-rays here on the CT scan, he did have also a subtle joint injury to his right sacroiliac joint. So breaking all these down, I just wanted to demonstrate how in this fragile pelvis, which typically you think of prostate cancer as more blastic and maybe a little more sclerotic, we had a very mixed situation with as much lytic lesions as blastic. We tackled this not only with CurvaFix implants, but also with cannulated screws, stabilized his joint, stabilized that LC2 corridor. But in this particular case, in those very curved areas of the superior pubic ramus or even anterior column, I was able to utilize these CurvaFix implants to help navigate these curved corridors with much more ease in an already tight situation with this patient with multiple implants. And this just shows how that can be done and how it can be navigated both from a retrograde as well as an antegrade standpoint, as you can see, left compared to right, and also how it can kind of blend and mix in and navigate through corridors that are pretty busy with other implants for other purposes. These are more final x-rays. These were 1 year out x-rays where he did end up healing. He actually did very well from a cancer standpoint. I thought he would have gone downhill, but he actually did pretty well. And I saw him up to a year, and he was discharged, and he had really no complaints, and was very grateful for how fast he was able to get up and move and return to really his baseline function. And you can note that there's sometimes in a more appropriate place to use this curved implant. In this particular case, I was comfortable with straight implants and cannulated screws in the posterior ring, but I really relied on that flexibility more for the anterior ring. And just some very brief other case examples so you can see some other applications where there's posterior ring applications, anterior ring applications, sacral, LC2, and just other places that we can utilize this, even in the posterior column. When we get corridors that are tough, that we can still treat percutaneously and get these patients moving, mobile, and active back to their baseline function, and hopefully out of the hospital as fast as possible. So with that, I'm going to turn it over to Mike and have him round out the last portion of the webinar. Thank you for your attention.
All right. Thanks, Samir and Rob. So what we're going to talk about here is kind of how you transition from a typical traditional pathway into, I'm going to term it more of a modern pathway, or the direction that the literature suggests that we should be going with this. So traditionally, as we've discussed, these are traditionally treated non-operatively. They're in the hospital for a number of days. Almost all of them go to a nursing facility. Afterwards, your length of stay is significantly high, your readmit rate's high, your morbidity and mortality are high. So what can we do to change that? And if we're going to look at doing that, I don't seem to have control. Katie.
1 second.
Okay. So the way that you go about doing this is initiating a quality initiative. So we're going to talk about what that is, why it's important, who are the key players in it, and then kind of what the steps that we've taken to do it at my facility. And I'm at a level 2 trauma center in southeast Kansas and southwest Missouri, trying kind of covering the corner of Missouri, Kansas, Oklahoma, and Arkansas here with a lot of elderly patients. So what's a quality initiative? So this is a focused action that's taken by an organization to improve access, services, and outcomes for patients. So what do you need to do this? One, you need a documented plan of action. That means you have to write something down, and you need a leader. And that is best if it's not the surgeon. The surgeon is very, very important with this, but you need an internal leader that can connect all the pieces. As Rob was talking about, there's a lot of players in this, and they all have to work together if you want to bring this all to fruition with it. So why it's important is because we're trying to change the old dogma of how these fractures are treated. You know, you hear it time and time again. I heard it through my training that these LC1 fractures are stable. They can weight bear on them. None of them need treated, but yet these patients don't get up and mobilize. And when you look at this, their morbidity and mortality very much mirrors what we've known for hip fractures for several decades at this point in time. So when you involve people in this, everyone needs to know what their role and responsibility is. And most of it for everyone outside of us is to recognize that there's a problem, there's something that can be done for it. And that's the key with what we can do is show people that there are different options than what's been traditionally available for it. So what are our goals with this? One, our ultimate goal is to improve the access to the patient population for this and direct them to the appropriate people for treating these, which is your orthopedic trauma surgeons. As Rob stated, there's really not another group of orthopedic surgeons that's comfortable doing this or properly trained to this. And from a hospital stay and a patient stay, we want to decrease that length of stay. We want to decrease the readmission rate. And overall, we want people to do better than what they do down the traditional pathway. So what did we do at my facility? Well, the first thing we did is we collected data. And there's several ways to do that. You can do it through internal sources, through your trauma registries. There's Medicare data out that you can look at, and you can get an idea for how many patients are in your region or your area that you can potentially affect for it. Next, you need a surgeon champion. Typically, that's going to be an orthopedic trauma surgeon, and that's the person who needs to put this idea and this treatment plan forward, and needs someone who kind of backs it. Then you need people to help coordinate it. And for me, I've used my trauma coordinator down here. I've used my clinic manager to all kind of bring all the different key players into place to make this happen. And then you need buy-in. And you get that by doing a few cases, doing a pilot program, and showing people that these people actually get up and walk and they get out of the hospital and they do better. They go home. They have shortened stays at the nursing facilities when they go to the nursing facilities, and do better. So, who's your stakeholders? Well, your patients are the main stakeholders. And this is one of the rare situations in medicine where honestly, everyone wins in this. The patients win with lower complication rates. The hospital systems administrators win because it's financially beneficial to them. Our financial stuff, when we've looked at it, mirrors some mirrors with it. Was actually slightly more than that a per case revenue, but in the same ballpark with it. Your providers all win with it because now you have something that you can offer to patients. You're not just having them in the hospital with PT, not being able to move, not to get out of the hospital. It helps you from a bed standpoint because you are moving these patients along. So it helps the throughput for your hospital. It helps your PT, your nursing staff, your social workers, because it all makes their job easier to move these patients along and back towards getting back home when they can get up and put weight on this and they're with a tolerable amount of pain and can walk and ambulate, even if it's with assisted devices. So I'm at a relatively small hospital. We have approximately 200 beds. So 9 months ago, all our patients were on a traditional pathway. And our length of stays were long, 9, 10 days in that ballpark with it. And none of these were being treated with an from a surgical standpoint. They're all being treated non-operatively. Over the last 9 months since we've implemented this initiative, we've really gotten buy-in. We started with the ER because that's the first touch point with people. So the first key to this is to capture all the people that are coming in the hospital and change that dogma of that there's nothing to do with these people. Present an option for them to do. So now we're currently treating 1 or 2 of these a week with it. We're probably treating 60 to 70% of these surgically at this point in time. I'm honestly, if they're not getting up and moving within 24 to 48 hours, we're looking at doing something to change their mobilization with it. Post-operatively, all our patients are mobilizing on post-op day 1. If they're non-surgical, they're mobilizing on post-injury day 1 with it. And our length of stay is dramatically decreased by about 50%, and our readmit rate is continuing to decrease with this. So now my focus is starting to change on not just getting the quality initiative started, but how do we continue with this? How do we branch this out to some of our sister hospitals and start bringing more patients in that can get a more appropriate treatment in this region? Because if you look at the numbers, there's several hundred of these that happen in my little local area with a population of about 400,000 people per year here, looking at the Medicare data from it. We're not seeing or treating near that many with it. So where are all these going? And my thought is that most of these are just not being recognized and they're still being treated along the old pathway and going to the nursing facility and ultimately not doing well with it. So we've had pretty good luck with all our emergency department providers, our hospitals, our trauma team coming on board with this. the biggest way to sell this is that these are another type of hip fracture. They're an immobility injury in a geriatric patient with it. And our next goal is to start reaching further outside the hospital with this. Where can things go wrong? Um, Again, people getting into that old dogma that we can't do anything with it. So you have to educate your orthopedic partners that are taking call because, if it's in my area, we have everyone from hand surgeons to foot and ankle to spine surgeons taking general orthopedic call. So they need to be educated that there's new technology, new ways, new thoughts on how these problems are being taken care of. You need to hold people accountable in a positive way, have expectations. When you have expectations, people seem to want to meet them with it. And when you have someone who falls through the cracks and doesn't go down the protocol pathway, then you need to use that as an opportunity to educate these people and explain the why. And as soon as you get people to understand the why of this, now you have someone who's bought into it and they are now out pushing this for you. And that's what we're seeing. That's growing throughout the hospital as people get the why of why we're doing this, is that it's getting bigger and bigger. And then you have to collect the data with this. You have to know what your length of stays are doing. You have to know what your implant costs are doing. You have to know what your readmit rate, what your complication rate is, because all that helps support the story and for you to move this along with it. This is an example of very basically what we put together for our Q&I stuff. You can scan on the PDF to pull a picture of the whole thing up. I think there's 3 or 4 pages with this, and this is basically just everything spelled out in writing with it. So it's a plan that you can hold people to, and they can refer to it if there's any questions for it. But you need to make it simpler than that, and that's what we did with these protocols. And this is coming, work out of a bunch of different centers with this. This isn't something we came up with our own here. This is something that I think is readily adopted across most places that are doing this as far as how to handle these patients with it. And the big thing is people that have an injury are getting down here to this ortho consult, to an orthopedic traumatologist, and that's where we weren't getting before with it. PT plays a huge role in this. We're having physical therapists now call us if they're seeing someone with pelvic pain that is not able to mobilize with it. So this has been a big change for us with it. And then you have to have some things that benefit the people that you're working for. So these are some of the med ed events that there's credit and stuff for that are available that CurvaFix has helped kind of put together a lot of these for us that we're using to help training that is on people's own time, where they don't have to be face to face with one of us for it. And things are going pretty well with this. I just wanted to point out one thing, is that we've kind of talked about these being low energy falls, low energy trauma, which a lot of them are, but don't forget the insufficiency fractures. I'm doing one lady tomorrow where she's just had a slow decline over her ability to ambulate and get out of bed over the last 6 to 9 months with it, without any trauma. And on her CT scan, she has a complex sacral fracture with bilateral alar fractures, now with a lambda and H pattern coming across the middle. She's kyphosing. She's getting radicular symptoms down her legs when she walks because the sagittal instability with bilateral anterior ring fractures as well with it. And this is just severe osteoporosis related stuff with it. And to kind of tag on to one of Rob's points, is that these fractures need to be kind of attack from all angles for it. Just operating on them is not enough. You need to have the osteoporotic treatment stuff on the back end of this, set up with a bone health clinic and everything else as part of your whole setup for this. And it takes a multidisciplinary approach to take care of these patients. Thanks, guys.
Thanks, Mike. That was great. Rob as well. Really informative, and really appreciate everyone's time. We just have a few minutes left. We're going to open up the phone lines, if you will, for our callers. So if you have a question, feel free to unmute and ask, or if there's a way to raise hands on Zoom, feel free, we can pick on you. Here's your QR code for your CME, so please take a screenshot of that, and you can get your CME credit. If people are sort of either rounding out to ask questions or potentially signing off. I have a couple of questions for our group, but again, very interested in what the attendees have to ask. My first question that I sometimes get, and it was in the chat room or the Q&A, I think I can't remember which one we answered. So why not just use traditional screws, right? Like, what's the functionality of using CurvaFix? Why can't I just use really inexpensive, traditional, straight cannulated screws like I've been doing for the prior decade and a half that I was practicing? And why do I need fancy things? Mike?
So I started off doing that in my practice before we had this available to us. And I think if you count backing out somewhat as failures, then probably 80+% of these failed to some extent with it. Also, patients didn't have the same amount of pain relief that you're seeing from this. And one of the things where my buy-in with this is that you're dealing with osteoporotic bone in these patients, and with a traditional screw, you get failure at the screw bone or the screw thread bone interface with it very early on with it. Whereas this implant has a couple things. One, with the curved nature of it, it is you have bone implant interface along the whole entirety of it. It also is not a completely rigid implant, so you get some give, some motion with it, with the cables that are there, even with the locked portion of it. And the three-dimensional curved nature of it is also a very good. It controls rotation, and there's always a rotational moment around your upper sacral segment, whether you're standing or sitting with it, where a traditional screw being in a straight line does not necessarily have the best biomechanics around that, and that's why multiple screws typically need to be used with it.
So there's a Q&A about that particular question, and I think it's probably in most instances that compression is better achieved with a screw, at least in this iteration of the implant. Stay tuned for additional future versions. But I sort of made the analogy of, a little kid wrecking his bike on a curb and bending his wheel, and he's walking that bike home there because that wheel does not want to move. The axle doesn't want to turn when it's bent. So if you have a screw or an implant, whatever you want to call it, that has a curvature to it that's rigid but locked within the bone, there is an inherent rotational and axial stability of that because of this bent axle concept that I paid attention to this when it was just screws prior to this implant use, and I just see people getting up faster and having pain relief to a larger degree with this implant. And I have challenged myself to not be anecdotal with that. And my early data in my first 30 cases has supported that claim. So I am officially a believer that I think that this particular implant has benefit when appropriately applied, that there is an additional stability that a particular linear screw does not have. But I would just, for the sake of completion, say that compression is probably best achieved by a screw if that's your primary goal, or you can mix implants and achieve one goal with one and another with a different one.
Mike, you mentioned that you're doing sort of an elective insufficiency fracture. I assume this patient came to see you in clinic like they come to see us, whether it's insufficiency from just pathologic bone or truly a pathologic fracture from, we have a large cancer center affiliated with our health system. And so we see a lot of sort of radiated pelvi. One of the questions was about insurance reimbursement. Are you having issues or seeing any issues with reimbursement for these electively scheduled pelvic ring injuries?
Not that I'm aware of. And typically, if we have those issues, they tell me about them pretty quick.
Rob, any issues with elective fixation of pelvic rings in the scenario, or even in the hospital? I mean, obviously these are trauma patients or they're ER patients, so there usually isn't an issue with reimbursement. But for those electively scheduled patients that you're using CurvaFix on?
No, I mean, I think the codes are independent of the implant for the procedure, so I haven't had any problem with that. I mean, all these patients carry a diagnosis that puts them in a DRG that supports reimbursement for their surgery. Um, so no, I haven't.
Yeah.
Like surgery is being denied. No, never been an issue. And I think it's important to say maybe too, also anterior or posterior ring because there are different codes. I haven't seen any problems with that.
Yeah, and I would echo those. I haven't seen any issues because the approval for the procedure is not directed based on the implant that you're using. And we have looked at that financially as well in our health system. That was the data that I showed earlier. Um, One last question. I want to be cognizant of people's time this evening. And the question really focuses on fixation, right? So, Mike, you mentioned that you're fixing more of these. I would argue that the number of pelvic ring injuries probably hasn't changed. I mean, I think it's going up, right, relative to maybe a decade ago because of the aging population. But these fractures have existed for a long time, and historically, as I think Rob, you pointed out, maybe Mike, it was you, only 10% or so were getting fixed, and 90% were being treated non-operatively. So, is this I always screw this saying up, I have a hammer and the world is a nail phenomenon? Like, why are we fixing so many more? What's happening? Are we just more aggressive, or so? What's the thought process around that? Because I'm doing more, you're doing more, Rob, you're doing more. So are we just more aggressive?
I mean, I think that the solution has become a little more apparent. And I think that the skill set, I mean, I think the volume of orthopedic trauma surgeons has grown. I think thought processes around particular different pathologies has changed. And I think the incidence of different diagnoses and injuries has also evolved and changed and grown over time. And this has just become something that we've started to see just have more awareness for that this particular population group when let's say 20 years ago an LC1 pelvis fracture, how many of those were happening versus now versus seeing how long those patients stay in the hospital where we're even like really worried about length of stay and where they went to sniff and things. We just were trying to avoid complications of surgery. Well, I think you now have a pretty large group of competent surgeons that can do percutaneous pelvis surgery that can address issues in a way that is really not that dangerous for you know for this patient population group. I mean, it's if you liken it to now, maybe it's not an apples to apples, but if you liken it to someone with a 6 or 7 8 inch incision for a DHS versus three percutaneous stab holes for a cephalomedullary nail, I mean, as things change, we've sort of evolved. I think it's our duty to evolve with the times. And, I think there's just a heightened awareness, increased skill set, and now increased availability of novel implants that can help maybe address a challenging problem from a unique perspective.
Mike?
Uh, so I think our tolerance as a society has gotten less for grandma's just in bed and she can't get up and walk. I don't think that the families are tolerating that the way they did a couple decades ago with it. Also, our elderly population has increased, and that's where we're seeing a lot of these. Our treatment for osteoporosis is not, at least in my region, is not good with it. It continues to be severely undertreated. So I think our recognition of these is going up, and also, our ability to do something positive with them is going up as well. my experience, these patients do better than I ever expect them to do most of the time with this. I mean, I remember the first lady I treated was a pelvic insufficiency fracture that seen on my spine partners for radicular problems with it. And, post-op day one, she was up walking. By 4 weeks, she was off her walker with it. And she'd had a problem for over a year with it from insufficiency fractures with it. I mean, it was pretty remarkable how quickly she got better.
Thank you both for your time this evening. Mike, Rob, I want to thank you again for the excellent presentations and sort of helping us understand how we imagine, evolve, and look at these and implement, right? I think everyone's got great ideas and they want to do the right thing, but the question is, how do you put it into play? How do you put it into your clinical practice? And I think what you both have described and have really done at your institutions is, implement pathways and implement care that wasn't available prior to utilizing this implant. I also want to thank CurvaFix for sponsoring this webinar. We've taken up much of your evening or part of your evening, and we appreciate your time. If you have any questions, I left my email in the webinar chat. Please don't forget to get your CME credit by using the QR code on the screen. If you have any questions or want to reach out or want more detail about the technical aspects or just chat about the procedure itself, I'm sure Mike and Rob will find either I'm volunteering them or voluntolding them, as someone used once with me, to help discuss the clinical applications of CurvaFix. Have a wonderful evening. Thank you for your time.